This program is brought to you by Emory University.
Good morning, everyone. Welcome to Heart and Vascular Grand Rounds. It is truly my pleasure this morning to introduce Dr. Arshed Quyyumi, who really needs no introduction. Dr. Quyyumi is a professor of medicine, a tenured professor of medicine, and also the director of the Emory Clinical Cardiovascular Research Institute, and holds the Bruce Logue Endowed Chair for Cardiovascular Research here at Emory. Dr. Quyyumi did his undergraduate degree in London in pharmacology and medical degree at the University of London. He completed his residency at Guy's and Royal Free Hospitals in London, followed by cardiology fellowships at the National Heart Hospital and Mass General and the NIH. After completing his residency and fellowship, he stayed on at the NIH and ultimately was a senior investigator there and director of the cardiac cath labs, and then subsequently moved down to Emory. Dr. Quyyumi's research has focused in various fields, including mainly vascular biology, angiogenesis, progenitor cell biology, mechanisms of myocardial ischemia and mental stress, genetic and environmental risk factors, disparities in personalized medicine. I could go on and on. He serves as a co-PI of a large observational study called the PCARS study, which he'll talk to us about today, about heart disease in South Asians. Dr. Quyyumi has published over 600 manuscripts, and as I mentioned, the H index of 128 and growing. And he serves on a lot of editorial boards, always invited to review for NHLBI, and serves on several scientific advisory boards. In addition to all of this, he helps me manage the ECRI Fellows, which is an important task, and has also helped with our new Clinical Cardiovascular Research Foundations course for ECRI Fellows. So thank you, Dr. Quyyumi, for always being available and for helping mentor our fellows and for giving this talk today on heart disease in South Asians. I'll turn it over to you.
Thank you very much, Pooja, for that kind introduction. And welcome, everyone. Probably an unusual topic, but a growing issue, I think, amongst the patients we are likely to see going forwards. So I start off with a bunch of pictures here, and if you can, in the text, tell me which these are, I'd appreciate it. See how many of you get these right. And we're grateful for funding that we receive at ECRI to do a lot of the research that we do. And today I'm going to spend time talking to you about data that we've acquired as part of the Precision CARS study that I show here, which was funded as an NHLBI program project grant. And what I'm going to cover for you is some epidemiology about cardiovascular disease, largely focusing on coronary heart disease in South Asians, the risk factors that may be underlying this increased risk, how we should do risk assessment, and perhaps the use of coronary calcium and the data that we have. And all of this is very patchy, and we have to kind of string together information that's out there because there have not been any sort of detailed population-based studies done in this population, despite the fact that 1 in 4 of the world's population is of South Asian origin. But what we hope to change this because recently the NHLBI funded a very large study called Precision CARS, where we are going to phenotype cardiovascular disease in a randomly selected representative population in South Asia. And I'll come back to that in later. But just to remind everyone, what do we mean by South Asia? South Asia is probably 7 countries in the subcontinent at the bottom end of Asia. And this includes India, Pakistan, Bangladesh, Nepal, Sri Lanka, Bhutan, and Maldives. You see this on the map there. The largest population is in India, followed by Pakistan, followed by Bangladesh. And it's a very diverse population. You can see them in pictures here, different cultures, different languages. It's many countries in one. And different shades of brownness. So everything is very diverse, and there are many, many languages, probably 22 major languages, 600, including dialects and things. And the reason for this diversity perhaps is the way migration occurred when man started to migrate out of Africa. It's assumed around 150,000 years ago. So some people went north and went through Middle East and up to Europe, and others turned around and came down into the Indian subcontinent that you see in the red line here. And then there was some direct migration to the south of India, also from Africa, that may have accounted for the diversity that we see here. Although there has been admixture over the years, there is still some distinct separation between the North and South on this kind of racial ethnic level. However, when you get out of the subcontinent, Asians are lumped together because the continent of Asia refers to the word Asian Americans, for example. In other words, it includes everybody in China and Japan and Southeast Asian countries. And if you count all of these different countries, almost 23 countries of origin, which account for Asian Americans as they are defined, that's about 7%, an increasing population in the US. It's estimated it's already increased by about 39% from the census 2010, so over a 10-year period, and is estimated to be the fastest growing minority population in the US. And it accounts for not just the South Asian population that we define up here, but also the Chinese, Filipino, Vietnamese, and Korean populations, which are some of the large representative populations from the rest of Asia, the East Asia and Southeast Asia. And these are very distinct populations by way of their ethnicity, their language, their cultures, as well as the disease prevalence, particularly cardiovascular disease, which we are going to focus on today. So lumping everybody into calling them Asian American, like a lot of the censuses and so on have done, have reduced the likelihood of us finding differences in these many ethnic subsets, which have many differences. Now, back to South Asians. A lot of the South Asian population, which is around 3, maybe rising to 4% of the US population, are located in large cities, in large states like California, Texas, New Jersey, New York, and Illinois. Around 6 or 7% of the Atlanta metro population is now estimated to be Asian, total Asian in origin. About half of them are from South Asia. So we are likely to see within our healthcare system an increasing number of these individuals. And you can see this migration over the last century and a half of how Asians were admitted into the US. Up until 1960, there was some law that prevented any Asian from actually settling in the US. So there was a moratorium. And then when that law sort of got lifted in the mid-60s, then there started to be migration in the sense that you could come and settle here in the US. And you can see there is this rapid increase in the Asian population, which is estimated to almost double in size in the next 30, 35 years as well. So fastest growing minority population. And because of that, I think more and more these will become individuals that the healthcare system will encounter and would have to know about differences amongst them. So here are some data that we have in the different Asian subsets in terms of their standardized mortality rates from ischemic heart disease. And you can see these lines from 2003 to 2017 are showing us age-standardized mortality rates. So you see that there is great diversity amongst the Asian populations in how this disease is going to affect them. For example, the lowest risk populations are the Vietnamese and those of Chinese origin. And then the South Asians is the green line. the ones that, or Indian Americans in this case. And you can see that even though in general, most of these ethnic subsets have seen reduction or flattening of their rates of ischemic heart disease mortality, the Indian Americans are seeing a gradual rise both in men and women. And here's data from the Kaiser Permanente, Northern California, sort of inside the healthcare system data, looking at individuals of different ethnicities in that area. So compared to the white population, the blue columns are showing total coronary heart disease incidence. Orange are men and gray are women. So compared to the whites, you notice that the South Asian population had much higher incidence of coronary heart disease compared, for example, to the East Asian populations, which have some of the lowest incidences. And then if you think of prematurity of disease occurrence, then South Asians also win on this. So for example, CHD appearing below the age of 40 is shown in the blue columns, below the age of 50 is shown in the orange columns. And you see that compared to the white population, the Asian Indian population has the highest, almost double the rate of CHD compared, for example, to Filipinos. And then Chinese have the lowest. There is also data from other immigrant populations, and this is data from the UK Biobank, and it's examining the rate of incident atherosclerotic cardiovascular disease over an 11-year period in a population that starts off with a mean age of early 50s in the UK compared to the European population. So this is only about 8,000 or 9,000 people who happened to be of South Asian origin who were enrolled in the UK Biobank study. And notice that the rate of CVD, atherosclerotic CVD, was almost twice as high, a little more than twice as high in this population. So you might think that the risk factor profile of the South Asian population in the UK would be much worse because they are now getting disease almost at twice the rate. But if you did look at the ASCVD pool equation or other equations that are supposed to predict future development of atherosclerotic disease, there's no difference between the two groups. The European and South Asian prevalence of ASCVD risk factors was exactly the same, totally overlapped, yet the incidence of disease was twice as much. So what is going on? And if you look at what type of atherosclerotic disease that's higher in this population, then all sorts of coronary disease, MI, non-fatal, fatal, revascularization, all these rates were more than twofold higher. And stroke rates were about 30% higher in the South Asians compared to whites. And then if you ask, is it just in men or women? No, it's in both. It's in young and old and middle age. And it's on people in the first generation as well as people who were second generation, although the numbers are quite small. So it wasn't just migration that was doing it, or it wasn't distributed at any particular age group. And if you looked at country of origin, and here are the hazard ratios that you see shown here, the highest risk appeared to be in the Bangladeshi immigrants in the UK, followed by Pakistani immigrants, and followed by Indians. But all of them had higher rates. Then if we start adjusting for all the risk factors that we know, the standard ones, hypertension, diabetes, renal disease, etc., but also add all the lipid profile, including Lp(a), inflammation, family history, diet, exercise, all of those things, even after adjusting for all of that, 45% higher risk of coronary heart disease compared to Europeans in South Asia. So just the ethnicity itself somehow, despite adjustment for all the differences in risk factors, causes much higher incidence of disease at a much earlier age. So if you start drilling into the risk factors and ask, where are the differences? Then you notice right away that diabetes incidence is a lot higher, and we're going to come back to this in a second. Central obesity was a lot higher, but other things like smoking rates were much lower in South Asians compared to other populations. So that gets us into, consideration of risk factors and each one of them in a little bit of detail to see where the differences might be that could perhaps enhance this risk. So as I mentioned already, diabetes is a lot more prevalent in this population. Here's data from India from the CARS study, Indian subcontinent. So it's from Chennai, Delhi. These are the two large megacities in the south and north of India, respectively, as well as Karachi, which is a large city in Pakistan. And surveillance of 10,000 plus individuals in each of these randomly selected from these cities shows a very high incidence of diabetes that you see there, and 20+% in the Indian cities and 16% in Pakistan. And of course, more than half of these individuals did not know they had diabetes when they were being surveyed. And this is not just peculiar of people living in home countries, but when they also are living in Europe or the United States, the incidence of diabetes or prevalence of diabetes is much, much higher than the local population, as it were. Notice the red columns are South Asians, blue are the native population, the majority ethnic group in those countries. So whether you're in the USA, United Kingdom, South Africa, Norway, or Singapore, if the South Asian subgroup who had much higher incidence. Masala is a study that was started, NHLBI funded in South Asian population in the US around 10 or more years ago. This is based by investigators in UCSF, with the sites being Northern California, Chicago, and New York. Only about 1,100 people in the early round. Most were immigrant, first generation. Majority of them were from India. Mean age was over 57. And they had been in the US for several decades. Very high socioeconomic status, highly educated and richer population, so not quite representative of South Asians in general, but nevertheless, it's a stab at trying to figure out what's going on with the South Asian population in the US. So comparing this population in terms of diabetes and why the prevalence might be high and drilling further into it, there are these two tests that are standardized, well-validated ways of understanding insulin resistance and insulin secretion. HOMA-IR is a measure of insulin resistance, and HOMA-beta, a measure of insulin secretion, the ability to increase insulin. Compared to other ethnicities in the four ethnicities that are involved in MESA. And notice how different the distribution is of insulin resistance, insulin secretion between South Asians and the rest. Notice that at a younger age, insulin resistance is far more prevalent in the South Asian population compared to all other ethnicities. That disappears in the older age groups, but insulin secretion is dramatically lower in the South Asian population at all ages, almost 30% lower. So striking difference where the reason why diabetes is occurring is very different in these different ethnicities. And even the way diabetes manifests appears to be a little different. So for example, in the South Asian population, highest proportion with severe hyperglycemia, a lot younger in terms of age of onset and more associated with obesity. Even gestational diabetes is most common in this South Asian women. There's data from Indian American women having the highest incidence of gestational diabetes in the US, and particularly if the woman was born outside of the US. This is associated with more than threefold increase of developing diabetes during lifetime. And the recommendations from the American College of Obstetrics and Gynecology is to screen for gestational diabetes very early in pregnancy of women from South Asia. So in summary, then, when you consider diabetes, much higher prevalence than local ethnic population, South Asians, wherever you look for them, almost a quarter of them, or just less, would be expected to have diabetes in the US in middle age. Occurs 6 years on average earlier compared to the local white population. And individuals who develop diabetes from South Asia don't actually look fat. or obese. It tends to occur at much lower BMI levels and is associated with elevated fasting glucose levels in the prediabetes stages and has this typical lipid profile of low HDL and high triglycerides that you often see in metabolic syndrome, for example. And the population has lower lean body mass at any age. The incidence of glycemic progression is also much higher. In the masala population, 32%, almost a third of the population, develop diabetes over the next 5 years. So what about fat, its distribution, and obesity in South Asians, and how should we think about this? So here's a nice picture or cartoon, if you like, that illustrates what is going on, which is not obvious to the eye. So here are two cardiologists. One is a European on the left and South Asian. Their BMI is exactly the same. But when you do MRI on them, you realize that the body fat content is dramatically different in these two people with the same BMI. Much lower body fat content of 9% in the European individual versus it was 21%. So there's a lot of hidden fat in the normal appearing BMI in the South Asian population because the body size is a lot smaller and muscle mass is a lot less. And here's just a joke that this guy has to keep this BMI by running marathons, while this guy, only exercise he does is run for an elevator door. So this sort of body fat distribution has been studied in the MESA versus the masala cohort in the US as well. And it shows that South Asians have significantly higher subcutaneous fat area, intramuscular fat, liver fat, so a lot of visceral fat everywhere distributed in the muscle, subcutaneous, visceral, in the liver, and much lower lean body mass as well, lean muscle mass as well. If you look at biomarkers of adiposity, lower adiponectin levels, higher resistant levels on average in the South Asians compared to the white population. So what do we think? What are the guidelines around obesity? The ADA, for example, says that BMI screening cut points should be very different for South Asians than they are for the rest of the world's population. And they suggest a cutoff of 23 and above for calling overweight in the South Asian populations and 27.5 as definition of obesity. So almost 3 points lower levels of BMI for these cutoffs than there are for the local population, and similarly lower cutoffs for waist circumferences as well in men and women. So if you use this cutoff of 27.5 for obesity, then almost 4 in 10 men and women would be classified as obese in the South Asian population, but not if you didn't use this lowered cutoff. And compared to European whites, South Asians have greater abdominal adipose tissue, and even in infancy have higher visceral and subcutaneous adipose tissue. So why is all this happening, and what are the reasons underlying this fat distribution issues, the diabetes epidemic in this population? So partly it can be attributed to diet, at least in the last 30 years when calories have become cheaper. And this detailed studies of the population in masala have sort of produced some of these results in trying to separate out people into those who consume a lot of these fried snacks and sweets, and which are very high in dairy. A lot of the so-called vegetarian diet includes this. So it's actually very unhealthy, associated with high insulin resistance and low HDL levels. And then those who are not vegetarian, consume animal protein, would be consuming a lot of the usual stuff that is not necessarily healthy either. And then, of course, there is this very healthy Mediterranean-style diet, which would be the third way of a third group. And I'll come back to that in a second, but also consider physical activity in South Asians, data comparing multiple ethnicities and multiple countries. In Interheart, for example, many years ago, but many other such studies have shown that regular and moderate physical exercise levels are lowest in the South Asian population compared to anywhere else in the world. The low physical activity itself is independently associated with prediabetes and diabetes and obesity, and also with CHD mortality. So what are the barriers? There are a lot of cultural barriers. There's just sort of lack of understanding of the importance of exercise. There are some religious considerations, particularly for women, that inhibit it. There are gender differences, there are generational differences. More acculturated individuals tend to exercise more. This is data from CARS, which is from South Asia. Almost 76% of individuals were sedentary. Of course, those who were sedentary had higher body weight, higher blood pressures, lower HDL, high A1Cs, and so on, as you'd expect. In fact, there was some evidence that just walking would, instead of sitting for half the time, would improve these risk factors in this population. So putting together these the diets and exercise levels, etc., this group came up with ways in which South Asians that have migrated to the US and perhaps to other countries have become acculturated in the local environment. So you could perhaps divide people roughly into three categories, where those who have maintained their sort of uh, the way they do things in their native countries versus those who were completely assimilated on the right here, and those who have taken have a foot in both worlds, as it were. Now, in the so-called separated class, they're more likely to be women, not in the US for as long, lower socioeconomic class, have lower levels of exercise and tobacco consumption, and generally eat this somewhat unhealthy South Asian diet. Whereas the most assimilated people would have lived in the US for longer, high SES, exercise more, drink more, smoke more, and have more animal protein consumption. So it's thought that the integrated class may have the best outcomes, and that seems to be the majority of when people have assimilated in the US. So the next question is it really just diet and exercise that has caused this epidemic that we are now facing of diabetes and cardiac disease? Or are there other lessons to be learned? And there are some imprints that go back centuries that probably impact the risk of these conditions that we now face in the 21st century. So, for example, if you look at mean birth weight distribution around the world, and this is data from almost 30 years ago, so these are people who are now 30 plus years old that have faced this at their birth. So notice that blue areas have an average birth of 2,800 grams versus the red areas have 3,500 grams. So almost 25, 30% larger birth weight in the European, North American countries compared to South Asian babies. A lot smaller. And this persists. This is South Asian population in the UK, looking at lean body mass index, which is really lean body mass adjusted for height. And notice that even teenage kids have lower lean body mass. So this is the second generation. And there are autopsy studies. This one is comparing Indians to French um, uh, autopsy studies that have not only found what we know, which is that BMI is a little lower, weight is a little lower, height is a little lower in the South Asian population. So this is how much lower the South Asians are compared to the French. But notice that all the organ systems are smaller. So, for example, pancreas is smaller, kidneys are smaller, spleen, liver are smaller, lungs are 30% smaller, the hearts are 30% lighter in South Asians on average. So if the heart is smaller, the coronary arteries are smaller, the lumen is smaller, and if you're going to develop atherosclerotic disease, it's going to block up faster. So there may be just a physical difference is making a difference in terms of cardiovascular disease outcomes, although there is some debate about that. And the other things is the pancreas is smaller, less number of beta cells, etc., so much more likely to develop diabetes. So all this has been put together in this hypothesis of load model of metabolic dysfunction, sometimes also referred to as the thrifty phenotype or thrifty gene hypothesis. And this balances metabolic capacity of an individual with metabolic demand. So, for example, if you are have excellent metabolic capacity, you'd be 3 here. But if you are of South Asian origin, you have lower birth weight, lower muscle mass, lower pancreatic beta cell mass, lower number of nephrons, smaller blood vessels, you are 1 here, more likely to develop disease, chronic disease. But then you add what happens to you during your lifetime, and you get exposed to the food and the lack of exercise, etc., that the cheaper calories, then you have this increased metabolic load to the system. So you end up at much, much higher risk because you're unable to maintain this or manage with this increased metabolic load with reduced metabolic capacity that you inherit or you're born with. So why have Indians or South Asians ended up being smaller and have low birth weight and have these issues? And there are some hypotheses, and these are obviously unproven because these are epidemiological observations. So it's thought that around 5,000 plus years ago, there was a shift to vegetarianism, with Buddhism having taken over as the majority religion in India. And that reduced animal protein intake, and it's thought that that also affected height of individuals, so it became more static and did not continue to rise as it did in the rest of the world. But the more recent explanation or what has happened is that India got occupied by the British, as most of you know, for almost 250 years in the 18th, 19th, and part of the 20th century. And during this occupation, there was a great deal of deprivation inflicted on the population by the British, although you would never read that in history books written by the English. There were recurrent famines, and overall calorie intake was, on average, much lower than it used to be before. In fact, before the British came to India, India had a GDP that was 23% of the world GDP. It was the richest country by far in the world. People used to go there to learn, to appreciate art, poetry, etc., etc. When the British left India, the GDP of India was 3% of the world GDP. So it was decimated over the 250 years. But part of the decimation was not just financial, but it was these recurrent famines that occurred. And it was overseen by the British in a way that would be called genocide now. For example, there's a good description of the famine in Bengal that killed 1 to 3 million people, where there was stacks of rice only 100 miles away, but Churchill refused to move it and actually shipped it off to England at the time. So these kinds of geopolitical changes that occurred in this population for hundreds of years led to a epigenetic change in the construction of the genome, which then leads to this, the thrifty gene, meaning it leads to insulin resistance, lower body size, lower muscle mass that increases insulin resistance, and so on that we now see in this phenotype. So anyway, that's an impact of geopolitics on human health. But I'll move on from there to other risk factors. Hypertension in South Asians about as common as it is in the rest of the world. um, which means it's very common, is often not treated. And here's some good data from the CARS study that I won't dwell upon. Dyslipidemia, it turns out that there is this pattern of dyslipidemia, of low HDL, high triglycerides, that distinguishes this population as opposed to LDL levels. The LDL levels, mean LDL levels, are similar, despite the fact that coronary disease incidence or prevalence is twice as much. And it's thought that ApoB may be a better lipoprotein measurement, which is a lot higher in the South Asian population than it is in the Caucasian populations or the white population. But this obviously hasn't become guideline as of yet. Also remember Lp(a), which is the most common genetic disorder that affects lipids and risk of coronary disease. The prevalence of increased Lp(a), high Lp(a) levels is a lot higher in the South Asians, 25% compared to 20% in the US population, and the highest in the African population, 30%. So if you had to summarize about dyslipidemia in the South Asian population, they have higher triglycerides, low HDL levels, higher ApoB levels, but similar LDL levels compared to the white population, for example, and higher Lp(a) levels. So the National Lipid Association recommends that if you have high PCU, pool cohort equation score, then it should be the target for LDL should be less than 70, so more aggressive treatment. And if you are at very high or extremely high risk, then the target perhaps should be less than 50 or even less than 30. The Indian Cardiology Society has also come up with this less than 30 as the goal for LDL in managing people with coronary disease from South Asia, although there is no clinical trial to show anything as of yet. Tobacco smoking, less often in the South Asian population, but also remember there are other forms of tobacco that some people, especially locally, would consume in South Asian countries, hookah, bidi, all those kinds of things, and also chew tobacco more often. And if you look at inflammatory markers, HSCRP levels are higher, as are other cytokines. So knowing all of this, how do we conduct risk assessment in South Asians if that person was to walk into your clinic and
good morning. Boy, it's chilly out there.
and how about use of coronary calcium in the screening? So the available guidelines are not really validated in South Asian populations, so there are no real studies to tell us what to think. So most of these are recommendations made without any clear trial data. It's also not clear whether the native population versus the migrant populations are very different from each other. And in many countries, because Asians are lumped into a group, there is really not good disaggregated data in terms of prevalence, incidence, et cetera. So the 2019 guidelines from ACC and AHA have said that in the equation, you should use South Asians as white, meaning as Caucasian, but also consider that ethnicity as a risk enhancer without telling us how to enhance that risk. But you have to think that there is an increased risk of whatever score that you get. But the ESC have gone further and said that whatever score you're using, you should multiply it by 1.3 for Indians and Bangladeshis, and for multiplied by 1.7 for Pakistani origin individuals, which will get you closer to their absolute risk. Now, when this Masala study, which is conducted in the US, looked at South Asians versus other ethnicities enrolled in MESA, then the amount of coronary calcium was similar in South Asians in men and women, more or less, compared to the white population, and higher than the other ethnicities. So it didn't encompass that increased risk that we observe in terms of the prevalence of disease, if just looking at CAC. But the differences were that there were higher number of vessels affected by calcium in the South Asian population and lower CAC volume and higher CAC density in the South Asians compared to the Caucasian or the white and the other ethnicities. And here's another way of looking at this is that if you were going to use the risk scores, for example, the ASCVD risk score, and divide people into low, borderline, immediate, and high, and then see how much CAC they had in each of these categories, then this is what it looks like. In green are individuals who were CAC negative. So if one focuses on, for example, the intermediate risk population, which is this column here, that more than 2/3, 70% of individuals had CAC in the intermediate risk group. Almost half of the individuals in the borderline risk group already had atherosclerosis. And even 17% of people in so-called low risk had atherosclerosis as measured by CAC. So it turns out, we have now, and you'll see this in a second, but in the precision cars population have looked at CAC in almost 3,000 randomly selected South Asian population. And the incidence there is about 38 to 40% in a population that is of mean age of 50-ish. So it's telling us that this disease actually is much more common than the risk factors it is that we are supposed to use to determine the presence of disease. So I think we need to start rethinking the way we screen for coronary disease in certain population, probably in all population, but certainly in this population where the risk factors, even though they are prevalent and some of them are highly prevalent, they're still less prevalent than the disease itself. So why not just go and measure it? So that leads me to the precision cars study, which is an NHLBI-funded program project grants, which means that it's 4 R01 grants combined in one with lots of cores and things. So we were very fortunate to receive this. Venkat Narayan with me are co-PIs, and there's a huge team of people, obviously, who work on this. And this is this study was layered onto the original CARS study that was started by Dr. Narayan and his colleagues 10 years ago and 15 years ago in two different cohorts that you see depicted here, collected from two mega cities in India, half of them from Delhi and half of them, which is in the north, and Chennai, which is in the south. So geographically different, ethnically somewhat different groups of individuals, and exposures like Delhi is highly polluted and Chennai is less. So very different in certain respects, but both South Asian populations, but obviously not all rural. It's all urban, not rural. And then around 2 years ago, we received this, or 3 years ago, we received this additional funding called Precision Cars Grant, which allowed us to do cardiovascular phenotyping in this cohort. This cohort was actually designed to study diabetes prevalence in this population. So now we have this study starting to look at cardiovascular disease prevalence. And it's a randomly selected population, like I said. So the population is totally representative of people living in South Asia, or at least in big cities. And it's done in a very detailed fashion where not only are we phenotyping them for underlying subclinical and clinical atherosclerotic cardiovascular disease and trying to understand the underlying pathophysiologic pathways and the risk factors, both traditional and novel, that might be responsible for that. But it's also embedded in very good data acquisition around socioeconomic status, health behaviors, built environment, etc. So like all the social determinants. The cohort is very large. It's over 21,000 people that were started to be, as I say, collected back then. 10 to 15 years ago, when the mean age of the population was 43, in two collections, CARS 1 and CARS 2, with very good follow-up, such that at least one follow-up visit has occurred in 95% of those individuals, which for a cohort is pretty amazing. 176,000 person-year follow-ups with a huge biorepository with tens of thousands of samples. So that made it easy for us to ask NHLBI to fund this grant in order to perform cardiovascular phenotyping and to understand and come up with precise prediction algorithms in this vast population that inhabits the Earth, 25%. And that is an increasing minority in many countries around the world. And as part of this study, we're doing the usual things of measuring socio-demographic factors, health behaviors, detailed family history, past medical history, physician diagnosed, medication use, psychosocial measures, ambient air pollution. So one of the projects in the PPG led by Dr. Narayan is around air pollution and its impact on cardiovascular disease and built environment, which is all geocoded. Anthropometry, blood pressure, glucose, insulin, lipids, renal, and cardiovascular events are being adjudicated. A lot of our fellows are involved in this process. And then in terms of advanced measures, we have all these biomarkers that I won't dwell into, advanced lipid measurements. And then we have whole genome sequencing that's now been funded through at least 3 to 4 different grants that'll occur in this whole population because GWAS was being done anyway. Epigenetics on much of the population, metabolomics on much of the population. And then in terms of cardiovascular phenotyping, everybody is having arterial stiffness testing done, carotid IMT and plaque measurements with carotid ultrasound, atherosclerosis assessment using CAC, and echocardiograms for measurement of heart failure prevalence in the population, and both systolic and diastolic, and CT scans that will also examine the liver for liver fat. There's Project 4, led by Shivani Patel and Amit Shah, is looking at activity and stress measurements using mobile technology. So this is a massive undertaking, but also a huge opportunity for Emory scientists, physicians, students, trainees to get involved. A lot of junior investigators are part of this network already, but there's clear invitation for many more to participate. You can see the massiveness of the undertaking. It is like having ARIC and MESA and a couple of other studies all in one in terms of size. And the phenotyping that's going on is extensive and vast, including most omic technologies, not just the usual phenotyping. The project, as I said, it has multiple projects, the cardiovascular phenotyping, the pollution aspect, the omics aspect, managed by Yan Sun, the spousal project using mobile technology that I just mentioned. Additionally, since getting this, there has been a diabetes grant awarded, R01, and a very large grant with the Healthy Brain Group, Alan Levy's group, which allows us to do MRI in this population, looking at cognitive decline biomarkers, brain health, and has allowed us to do whole genome sequencing that helps us. There are many other grants being designed that have been submitted or being submitted around the lung function, which is also, as I showed you earlier, not just in size, but in functions, about 20 to 30% lower in this group, and seems to be an independent risk factor for cardiovascular disease. With liver fat being a huge issue, there's a grant around liver. Our hypothesis was that CAC was underestimating the amount of coronary artery disease that is present in the population, and we've written a grant to perform CCTAs in this population as well, and around kidney function as well. Many of our investigators are getting involved. There is a large imaging core group of individuals that we see here who are performing QC on the imaging that's going on. It's very easy to get involved. There is this website that you can go on, or you can let me know. And Carrie Ann Roy is our coordinator. If you go to this website, there is this PPNA form, which you can fill in and say what your interest is and what data you want to write or grant that you want to write or data you want to access to explore, etc. It's very easy. And this committee meets twice a month or so to take care of the application. So a huge resource for Emory that should transform the way we do research here over the longer term, and it'll be a huge opportunity for junior investigators in particular to advance their careers. So thank you very much for your attention. All this work occurs as a result of a huge collaborative team, particularly the workers who make this cohort function and have done for the last 15, 20 years, and many partners around the world. The main centers in India are All India Institute of Medical Sciences, CCDC, which is a chronic disease center, MDRF in Chennai. And of course, Emory is the lead institute here. Thank you very much for your attention.
Thank you, Dr. Quyyumi. That was tour de force of the landscape of heart disease in South Asians. I'm going to open it up for questions. And while people are thinking about the question, I'll start off with asking, so when you see a South Asian person in clinic who has known ASCVD, has had an event, MI or stroke, do you target LDL less than 30 based on the Indian guidelines?
I actually don't, but I tend to target it to a lower level. But so for example, I don't add a PCSK9 because nobody actually gets down to 30 unless you do. Because it's not really a firm guideline, it's a recommendation. It's like, and there's no, as you know, there's no trial data to support that, except to know that the risk is so high that it doesn't seem to disappear if you go to below 70 and stay there. So the hope is that by driving it even lower and lower and lower, you would get to, you'll get some benefit. But maybe we should,
Mm-hmm.
There's probably never going to be a trial to show that it does. So we would have to go with these kinds of recommendations.
Neil, did you have a question? I think he unmuted.
Oh, that was accidental. I was just transferring to a different audio.
Yeah, no problem. So, my other question is that, we've always thought of heart disease as a lifestyle disease, right? Like 80% of it or so, we say that it's all, lifestyle. Whereas this hypothesis that you showed with sort of underlying predisposition from the minute you're born, do you think that that's unique to Indian population? Or, isn't that true for a lot of probably heterogeneity for, Africans or Hispanics or, so it's not just Indian, right? In terms of, just wanted to hear your comments about that.
Yeah, no, that's true. This data actually is better worked out in, for example, the Dutch population who was starved during the Second World War by the Germans. And so that kind of data is out there on how it leads to epigenetic changes or mitochondrial DNA changes that get transmitted from generation to generation, may take time to wash out. But it still remains, it's not slam dunk, that hypothesis. That's why I say that with some, because the true, what epigenetic change is driving this, etc., has not been fully worked out, although there is an imprint of starvation or calorie restriction that occurs. And the British and other occupiers around the world, and this still happens now, have used this weapon for a long time. And they've done that to the Africans and many other places. And so this sort of phenotype has been persistent in many places. But this is a vast population sort of that where you could study it and see it now manifest in this way. For a long time, back 70 years ago, coronary disease wasn't an epidemic in that part of the world. And there is data to show that, the hospital admission records and so on, heart attack was very infrequent. But it's now sort of taken off as the most common condition that they see. So this is like that epigenetic background with this calorie excess and the lifestyle changes that have occurred very quickly within a generation almost, that sort of together have led to this imbalance between your makeup, which was there to succeed, right? I mean, if you're starving, you better be insulin resistant and keep every calorie for yourself so that you can survive. But then you expose that phenotype or genotype, if you like, to these excessive calories that we now have and are cheap. And then you end up with this high risk of chronic disease, it
Thank you.
seems.
There's a question in the chat from Dr. Taylor. The obvious question from me, the idea that the coronary arteries are smaller is interesting since geometry is a major driver of shear stress. Has anyone ever done biomechanics modeling to see if shear stress is different? And along the same lines, just collateral formation also, and any information on that?
These are great questions, Bob. And the data is very rudimentary in this whole field. Certainly nothing like shear stress that I know has been done in coronary arteries across ethnicities. But just by geometric principles, you would think that what you're saying is correct. But it needs to be done. And there are now planned autopsy studies. And maybe we can get more involved with those because that I think is partly where the problem is, perhaps, other than all these other susceptibilities that we talk about. But this arteries being smaller is not fully accepted. There's data going both ways. And so I don't think we can sort of make that as a definitive statement.
So I'll intentionally unmute this time, Pooja. So Arshed, I'm curious whether and my guess is it's going to take work like what you're doing now to start to get a sense of whether this is true or not. But given sort of some of the background differences that you've observed in body composition and whatnot, is that suggestive that there's a really important role for things like exercise and other kinds of lifestyle modifications that may be potentially disproportionately helpful in this population?
Yeah, there are a lot of studies doing this, at a community level. I'm not a lot, but there are some studies that are actually studying this whole issue, Neil, of changing how much exercise people are doing, or at least educating them in the benefits and all of that kind of thing. Whether this will, like you say, have a disproportionately larger impact in this population or not will have to be tested over time to see. But, having dwelled on sort of very high risk in this population based on these things, I have to say that there are many people who live to 110 as well, who are very thin, and who exercise in different ways. There's, again, not time to discuss all of this, but they meditate, they do things. I mean, there are many other ways of living a healthy life within that culture that is associated with longevity and preservation of faculties, etc., that one has to learn from. But what's happened, I think, in the last 30 years is that the availability of cheap calories has sort of swung the whole thing in this population to this extreme phenotype of very high risk of diabetes and cardiac disease to go with it.
Okay. Are there any other questions or comments?
Arshed Stan Sherman, are you more likely to do a stress test in the South Asian population now, given what you've learned?
More likely to do stress tests, did you say?
Yes.
I would err towards doing much more CAC at an earlier age. If you're going to screen in a different way than just doing your ASCVD risk score. Because the risk score, as I showed you in some of these different slides, grossly underestimates the actual risk. Now, you have to do a risk score, then multiply it by something and imagine that you classified them to a higher risk, etc. So, and then the other part of this is that you have to persuade that individual to start swallowing statins and other things, which is always a hard thing to do in people who don't think there's anything wrong with them for for the rest of their lives. So in order to make that leap forwards, I think it's so much easier to do a calcium score. And then And now having done that, then the question arises, should you do a stress test or a CCTA? And so on. So that's another discussion entirely. I would err towards a CCTA in the current era because we've had enough people with zero CAC and terrible disease in this population. And in general, about 10% of people will have non-calcified plaque. So if already the incidence or prevalence of CAC is 38%, and you add another 10% of non-calcified, you have 48%. Half the population by the age of 50 has coronary disease. Well, it's much more common than all the risk factors. So why not just go straight to what you're trying to treat and then treat it?
Okay, any other questions, comments? If not, then thank you again, Dr. Quyyumi, for going through this very interesting topic and reviewing everything for us this morning. And thank you everyone for joining. Don't forget to get your CME, and I'll see everyone next week.
The preceding program is copyrighted by Emory University.